I'd like to say that starting a lymphedema program may have been one of the better ideas that I've had, but it was truly a 20-year odyssey, often beset by challenges, obstacles, many defeats, many victories. And I'd like to share those with you in the next few minutes. 99% of what I'm going to tell you is historical fact, 1% whimsy. You'll be able to tell the difference, I'm sure. So let's start. At first, I thought I ought to change my title to this, because back 20 years ago, back in 1981 rather, no one was thinking about this, and certainly in 2002 when we began the program, it still was considered a dream more than a reality. I have no financial disclosures. In 1981, I was a microsurgery fellow at Bellevue Hospital, New York University Medical Center, training with Dr. William Shaw, a renowned microsurgeon who was responsible for the education of Ming-Wei Chen and other notable and distinguished leaders and professors in our field. We didn't know much about how to take care of simple cases of lymphedema. We didn't have the basic understanding of the clinical and research processes, and we certainly didn't know how to take care of the difficult cases like this patient with end-stage lymphedema of the hand, or a woman with severe obesity and secondary lymphedema. These cases overwhelmed us at the time. What was the problem back in 1981 and extending right up to 2002? Who was going to provide care for the lymphedema patient? There was very little education in the medical schools, including Harvard Medical School. There was almost no funding. Bill Rapisi could tell you about what an obstacle that was. And there were few, if any, specialized clinics in the United States that dealt with this problem. So who was going to take care of these patients? Well, basically, I regret to say that no one really wanted the lymphedema patient for a number of reasons. It was challenging because we didn't have cures or clinical solutions. We didn't know how to manage these very complicated cases. And the insurance industry did not reimburse us for these efforts, and in many cases, simply refused to pay for any of the procedures by saying that they were experimental in nature, and that was the excuse that they conveniently gave us. So after returning from Bellevue to Boston and Harvard Medical School, I started doing the cases that I had learned to do in New York, including microlymphaticovenous anastomoses. And we did a number of these, and we thought that in some cases the patient was improved, and in others not so much. I presented many of these cases at national meetings, and I noted that there was some clinical improvement, but it wasn't clear how many anastomoses you had to do. We started with 3 or 4, and I used to joke with the patients, this is going to hurt me more than you, because I'd be under the microscope. And in those days, there were no microsurgery fellows. There was one resident at Beth Israel Hospital at the time in training in plastic surgery. So the training of the plastic surgeon became an important issue because we began to ask, who will be the lead surgeon for treating these difficult patients? And it became quickly apparent that the plastic surgeon was the ideal choice. Why is that so? They had training in extremity surgery. They understood microsurgery. They were experts in breast cancer reconstruction. They knew some of the techniques, such as liposuctioning, that would be extremely important. They treated congenital deformities, and they were able to manage almost any complication in surgery because almost all of them had full surgery training in general surgery. Now, let me give you a brief aside. I'm a diehard Red Sox fan. I'm a season ticket holder. And back in the late 1990s, the Red Sox offered season ticket holders the opportunity to purchase their seats, and they were installing new seats in the park, not much different from these, by the way. And so I quickly called them up, and I said, yes, I want to purchase them, and I was successful. And then I called my wife, and she said, you what? So the seats were purchased, but my wife insisted that they be put in the basement. Okay, so in the basement, in my Red Sox tickets, I cogitated, I ruminated, I pondered, And I came up with some decent ideas every now and then because it was very quiet down there in the basement. It's now the year 2002. I was chief of plastic surgery, and I had the opportunity to do something about this problem that had bothered me for 20 years. So the idea came, let's start a lymphedema center, the core of which would be a lymphedema clinic. So how do you do that? Well, first you have to know what to do at the clinic and how to treat the patients. And Dr. Bronson, the great pioneer in liposuctioning techniques, already had a record from the 1990s as to how to treat these patients. So I decided I better fly over to Malmö, Sweden, and watch him do it. He was extremely accommodating, and I thought it would be a great idea to take Dr. Jay Austin, our chief resident that you see here, with me to help me start this lymphedema center. So we traveled to Sweden, and we learned from Dr. Bronson how to do this procedure. But lo and behold, when we got back, the insurance companies told us, that's experimental. And we said, but wait a minute, Dr. Bronson has already published numerous papers demonstrating the clinical efficacy of this technique. And they said, that's experimental, and they denied our cases, unfortunately. The next obstacle in this odyssey is the administration. You need an administration that is congenial, helpful, and supportive. And at that time, this is the response I got when I said, we need space for a lymphedema center and clinic. And I looked at both sides of the street. There was this vast medical center called Beth Israel Deaconess, and the administration said, sorry, there's no space. Now what do? You go to your mentor, Dr. Robert Goldwyn at that time, a very famous plastic surgeon, professor of surgery at Harvard, and former chief of plastic surgery of the division at Beth Israel Deaconess. And I said, Bob, they're telling me there's no space for a clinic. And he said, listen, if they give you nothing more than a closet in the basement, you'll take it. Okay? I started looking around at basements. I looked all over the medical center. I found a few basements that looked like they might work, but none of them were really suitable. So the second problem, they finally relented and they said to me, you can piggyback your lymphedema clinic on top of the plastic surgery clinic. Well, when would that be? The plastic surgery clinic met on Fridays from about 1 to 4 o'clock. Dr. Slavin, you can have 4 o'clock onward on Friday afternoons. Okay, I told the residents that we'd be starting this clinic, and some were a bit grumpy about it, but they nevertheless came over to the clinic with their usual enthusiasm and intellect and helped me start this program. It was certainly clear that the clinic conflicted with some of the residents' activities. What would you rather do? Fortunately, these highly motivated young people chose the right choice. So the next problem, we were doing research at the Massachusetts General Radiation Biology Laboratory and also at Dana-Farber. And we were experimenting on rats and mice and trying to create lymphedema and then try various solutions in the laboratory. Now the veterinarians. The veterinarians were the supervisors of these research laboratories, and they were not the fuzzy, puppy-loving type that we all know. What we got were people who said, you can't do these experiments, they're cruel to animals. Well, what do you mean? Well, you're creating swollen limbs. But isn't that the idea of the experimentation? So they shut down our program because they were unhappy with the pain that we were inflicting on rats and mice. And as you see, we're able to establish a chronic lymphedema model in the rat hind limb. And we were also able to show in 1999 that tram flaps, rectus abdominis myocutaneous flaps, could be transferred to a lymphodematous tail, and they would relieve the lymphedema. It was a precursor of much of what we're doing now. Now the clinic. The residents, as I said, enthusiastically endorsed the clinic, and discovered very quickly that this was a gold mine of academic research and potential findings. And one of the first papers was by Dr. Evan Garfine, then a resident, entitled Learning from a Lymphedema Center. He is currently Chief of Plastic Surgery at Montefiore and has written papers on lymphedema. The word got out that this clinic was flourishing, and it began to attract some of the best minds, not only teachers and residents, but also students. And Ann Pellard Warren was a Doris Duke Fellowship honoree. And one day she called me and she said, I understand you're doing some very exciting things. Can I spend a year with you? I said, absolutely. She published 8 papers in 1 year as the Lymphedema Research Fellow, a third-year medical student at HMS. Melody Swartz was a research fellow, and she conducted research with us, and she is now a named chair and professor at the University of Chicago. Aaron Green, I hope he's in the audience, I don't know if he is, another former resident who quickly recognized the value of the lymphedema clinic and center that we were trying to create, and one day said to me, we need to write a book, and we did. And this book, co-authored with Dr. Brorsson from Sweden, came out in 2015. So the clinic has been extremely academically productive from its inception in 2002 up until 2009. What happened then? We were producing papers, and as you can see, we were publishing in many name-worthy journals, New England Journal of Medicine, Plastic and Reconstructive Surgery, and the papers flowed like water, one after another, after another. But the hospital said to us, you're losing money. Well, what do you mean we're losing money? Well, we can't get reimbursements for much of what you're doing. And I said to them, are we a hospital or a bank? And they replied. The importance of teaching lymphedema became even more emphatic to me when our fellow from 2015, Dr. Ginger Shu, who is now out in San Francisco, called me excitedly after she had just completed the American Board of Plastic Surgery certifying exam. And she said, you won't believe this, Dr. Slavin. Of the 7 questions that the board asked us, one of those 7 cases was lymphedema. She said, I aced it. Okay, that was great. And now let me conclude with Dr. Singhal. Dr. Singhal is an extremely important person because he alone has pioneered our current program. He resuscitated it, and he created something brand new. He has developed a multidisciplinary team, new techniques, new approaches, new research, and as a result of his leadership as the Director of Lymphatic Surgery here at Beth Israel Deaconess, we have this wonderful symposium. Thank you, Dr. Singhal. Drew, I feel vindicated.
And that's why he's our honorary chair, Dr. Slavin.